Hello and welcome. This is A&P Live Studio. I'm your host, and I teach A&P as a registered nurse and anatomy and physiology instructor for advanced level healthcare pros. You know, a sudden noise, a crowded room, a recurring nightmare. For millions of people, these aren't just passing moments. They're these persistent, painful echoes of trauma. Today, we're going to break down the complex neurobiology of post-traumatic stress disorder, or PTSD, to really understand what's happening when the brain's own alarm system just can't be switched off.
So, here's our plan. We're going to trace the path of PTSD from the outside in. We'll start with a clinical scenario, then we'll dive right into the brain's normal fear response to see how it gets hijacked by a traumatic event. After that, we'll look at how that affects the entire body. And finally, we'll explore some of the really incredible ways we're learning to reset that system.
So, let's start by grounding this really complex condition in a human story. I want you to meet Sergeant Kenji Tanaka. He's a 34-year-old combat veteran, and he's been brought to the emergency department by his family. They're really worried about his behavior since he's been back from his deployment.
He's telling us about these awful, intrusive nightmares. He's irritable, quick to anger, and feels like his heart is just racing constantly. You know, a car backfiring can send him diving for cover. He's even started avoiding crowds, can't bring himself to go to veteran events. His symptoms really paint a classic picture of post-traumatic stress. But to understand why this is all happening, we need to take a step back and look at how the brain's fear response is supposed to work.
So let's set up our baseline. We're going to deconstruct the brain's healthy, its adaptive fear circuitry.
Okay, so it all begins with the amygdala. The best way to think about it is as the brain's supersensitive smoke alarm. It's constantly getting sensory input, everything we see, hear, and feel, and it's scanning that input for any potential threats. If it perceives danger, it immediately triggers that initial fear response.
So next up is the hippocampus. This is our context memory center. It takes that potential threat and it cross-references it with all our past experiences. It helps the brain answer the question, is this danger for real? And what happened last time I was in a situation like this? This context is absolutely crucial for an accurate assessment. And finally, we have the medial prefrontal cortex, the NPFC. This is the rational fire chief of the whole circuit. It evaluates the situation using our higher executive functions, and once the threat is gone, it hits the brakes. It sends a signal to the amygdala to turn off that alarm.
So, you see, in a healthy system, this whole process is just elegant and so efficient. A threat is detected, the context gets assessed, the threat passes, the NPFC gives that all-clear signal, and our system goes right back to baseline. This is how fear is designed to protect us, not to harm us.
But in PTSD, this beautifully tuned circuit gets hijacked by trauma. And what that does is create this persistent and frankly debilitating state of alarm.
And right here you can see the side-by-side comparison. It's so stark. In PTSD, the amygdala becomes chronically hyperactive. That smoke alarm is just stuck in the on position. At the same time, the NPFC becomes hypoactive. The brakes are failing. And to make matters worse, this imbalance is compounded by changes in the hippocampus, which can actually show reduced volume. That leads to these fragmented memories that just don't have the right context. These changes in the circuit are driven by a whole cascade of neurochemical imbalances. For example, noradrenaline levels get chronically elevated, and that's what fuels the hyperarousal in those awful nightmares. Basal cortisol levels are often low, which actually messes up the HPA axis's ability to provide the negative feedback it needs to shut down the stress response. So the key takeaway here is that this isn't just a structural problem. It's a deep, profound chemical disruption.
So now, let's explore how this disruption in the brain doesn't just stay in the brain. We're going to see how it shows up as clinical symptoms and creates widespread complications all through the body. So you might be asking, how does an issue in the brain's fear circuit become a whole-body disease? Well, the answer lies in the chronic, relentless activation of the body's main stress pathways, the sympathetic nervous system and the hypothalamic, pituitary, adrenal, or HPA axis. This slide really brings it all together. We can literally map Sergeant Tanaka's symptoms directly back to the pathophysiology we've just talked about. His exaggerated startle response? That's his hyperactive amygdala. His emotional dysregulation? That's the hypoactive NPFC failing to dampen the fear. And those intrusive, vivid nightmares? They're being fueled by that elevated noradrenaline and a hippocampus that's struggling to put his memories in context. And this nervous system dysfunction, it just radiates outwards, setting off a cascade of effects. It's a perfect example of how a disruption in one area starts to impact multiple other organ systems, everything from cardiovascular to endocrine. This really defines PTSD as a truly multisystemic condition.
And the consequences are staggering. Large studies have shown that having a PTSD diagnosis is associated with a 27% increased risk of having a major cardiovascular event or even dying from cardiac causes. That chronic sympathetic drive and systemic inflammation, it just places a huge burden on the heart and the entire vascular system.
And this leads to tangible, widespread disease. For the cardiovascular system, we're talking hypertension and coronary artery disease. In the endocrine system, that HPA axis dysregulation contributes to metabolic syndrome. And in the immune system, we find the state of chronic inflammation, with elevated pro-inflammatory cytokines like IL-6 and TNF-alpha.
Okay, so given all this complexity, how do we actually diagnose PTSD? And more importantly, how can we intervene to try and restore some physiological balance? Well, the diagnosis is mainly clinical, right? It's based on those symptom clusters that are defined in the DSM-5. But what's so fascinating is that neuroimaging studies consistently show us the underlying pathology we've been talking about, that hyperreactive amygdala, a quiet MPFC, and a smaller hippocampus. Now, these aren't diagnostic tools just yet, but they absolutely confirm the biological basis of the disorder. So, frontline pharmacotherapy often involves SSRIs and SNRIs. By making more serotonin and norepinephrine available in the synapse, these medications can help modulate mood. And crucially, they can help dampen those overactive fear circuits, kind of like turning down the volume on the amygdala's alarm.
There's also a really interesting emerging intervention called the stellate ganglion block, or SGB. This procedure actually targets the sympathetic nervous system directly. By injecting a local anesthetic near this cluster of nerves in the neck, it temporarily blocks that sympathetic outflow. This can help reboot the body's chronic fight-or-flight state and can dramatically reduce hyperarousal.
Another really innovative approach is MDMA-assisted therapy. Now, in a controlled therapeutic setting, MDMA seems to reduce amygdala reactivity, while at the same time increasing activity in the MPFC. What this does is create a unique neurochemical state, what they call a window of emotional safety. And that allows patients to reprocess their traumatic memories without being completely overwhelmed, which can facilitate some really profound psychotherapeutic work.
All right, let's wrap this up by recapping the entire pathophysiological journey that we've just covered, from a balanced system to a dysregulated one, and hopefully back again.
This framework really summarizes our whole discussion perfectly. We start with a balanced fear circuit. Trauma comes in and hijacks that circuit, which leads to that core pathophysiology of a hyperactive amygdala and a hypoactive MPFC. This then shows up clinically as hyperarousal and systemic inflammation. And so, logically, our treatments aim to directly target these disruptions to try and restore balance to the whole circuit. I think understanding PTSD as a physiological injury, not some kind of personal failing, just completely transforms how we approach it. It shows us a brain and a body that are stuck in a state of emergency, but it also points us toward a future where we can learn to guide them back to safety.
As always, this presentation is for educational purposes only and is not intended as medical advice. Stay patho-curious, and I'll see you in the next episode.